everyone, and welcome to today's D-Series. My name is Carly, and I'm the Entrepreneurship Program Manager here at the UCSF Rosenman Institute. And today I have the pleasure of introducing our talented guest, Liz Canis. Liz is the founder and CEO of the Pivot Group, which provides strategic consulting and advisory services for businesses looking to accelerate their growth through healthcare partnerships. Liz has a very impressive background in a variety of leadership roles at both Anthem and United Healthcare Group. At United Healthcare, she led the strategy and implementation for state and private exchanges and developed a keen understanding of consumer behavior engagement and risk management. And at Anthem, she was Vice President of Emerging Businesses and Partnerships, where she led innovation and commercial initiatives. We are so lucky to have Liz join us today to share her insights and wealth of knowledge on the payer value creation model and whether a payer relationship may benefit your business. Liz will be taking questions throughout the talk, so please share your questions below in the Q&A at the bottom of the screen. And with that, I will pass it over to you, Liz.
Thank you, Carly, and pleasure to meet all of you. Good afternoon. I'm going to pull up my screen here. And as Carly mentioned, I'm happy to take questions throughout. I have a couple of topics I'd like to cover today. The first is just to kind of level set on some fundamentals about the payer industry itself, participants, key components that really matter to payers in general. Then I'll spend some time going through what's the real payer perspective and how do they think about potential partnerships or investments, and particularly how they evaluate earlier stage opportunities. The last is I'll just spend a little bit of time giving some thoughts on how to think about navigating a payer organization. As Carly mentioned, I've spent about 15 years between United Healthcare and Anthem. They're very large companies. It sometimes takes a little bit to really kind of understand the dynamics, who the decision makers are, and who are ultimately the potential partners or eventual customers for your business. So first, thinking about payers in general, there really are multiple types of payers. The federal and state governments that we have today operate as a payer. We have the federal government with CMS that oversees the Medicare business. They also play a very large role in our state Medicaid programs, and then the states actually will manage the different Medicaid beneficiaries and benefits overall for their states. Another key thing to highlight, though, as we think about government as a payer, is that they're also a regulator. So when you look at the next three categories, which is what we refer to broadly as sort of the private payers, as we think about the regulations, they're established by those federal and state governments, and the private payers need to adhere to and be compliant with the various regulations. Probably the largest bucket that many of you are familiar with is the health insurer category. This refers to national institutions such as United Healthcare, Aetna, Cigna, Anthem, and others. Could be regional players that operate in multiple states. It could be local players when you think about a lot of the Blue Cross Blue Shield companies, various community-based organizations. They may be for-profit or nonprofit entities. And what we're seeing a lot in the health insurer space is that many of them are starting to expand into other services, thinking about ways that they can improve how they service the beneficiaries and their covered members. So many of them are getting into pharmacy management. They're looking at health services more broadly, which can be anything from care delivery assets to digital to analytics, a number of different sort of things. Then we have our employers. And many people think about employers as offering coverage, and they do. Smaller employers tend to engage a health insurer if they are having the health insurer manage the risk of their population. So that's referred to as fully insured business. And the easiest way to think about that is that there is an employer who is going to make coverage available broadly to their population, and they will write a set amount of payment on a monthly basis for the premium to cover those individual employees and their families. Now, larger employers may choose to do something that we refer to as self-insure. This is where they will pay an administrative fee to one of the larger health insurers or even a local health insurer. This affords their beneficiaries access to the networks. It allows the individuals to leverage the claims processing, the care management programs, and really just oversee all of the benefits. So any of the call center activity, when a member has questions, will go through the health insurer, but ultimately all of those expenses are paid for by the employer. So any medical expense, any consumption of services will be covered by the employer. Then we have providers. So we do have a number of providers that are beginning to expand their role and presence in the payer space. Some of them are integrated plans as we think about Kaiser Permanente or Intermountain Healthcare. Some are just providers themselves who are creating their own individual benefit offerings. This may be Ford Medical System, and various others are springing up. It still represents a relatively small portion, but we are starting to see a number of them take a bigger role. And something to think about with these providers is they may often limit the interaction with those patients across their specific health system. They desire to build a relationship and keep that member within their health system. A couple of other things to think about too is just how do the various populations across the US think about accessing care? So this is just an attempt to break this down to give you a little bit more visibility in how we think about the market. So there's about 55 million, maybe a little bit more, that are in Medicare. And what's important to note here is that we have about 11,000 people aging into Medicare every day. That's going to continue to progress that way until about 2030, when our baby boomers have really all aged into Medicare eligibility. Now, within Medicare, we are looking at seniors who are 65 and above, and the risk-bearing entity for the Medicare population is the federal government and also private payers who offer Medicare Advantage solutions. And the Medicare Advantage portion of the population is about 40+% right now. It's growing as many of the Medicare eligibles are looking for increased benefits and support that they can get through private payers. We then have Medicaid and CHIP, and CHIP refers to the child offerings that Medicaid, state Medicaid programs have established. This tends to be lower income Americans. Individual states will establish their Medicaid programs, and then they will typically contract with private payers, referred to as managed Medicaid organizations, to oversee the benefits and support the patients that they cover. There is a fairly healthy individual market. This represents those that are purchasing coverage for themselves or their families on their own. And this tends to be the private payer market. Many of you have heard about the state exchanges. They are overseen by the state and federal government, depending on the individual state. But really, the payers that are offering are those from the private market. You'll then see that the bulk of the population in the US, nearly half, receives their coverage through the employers. So we have smaller employers, which tend to be those that are less than 50. These are generally the ones that will take a fully insured route, where they will contract with a payer and write a premium check on behalf of their beneficiaries, and then the private payer will bear the risk. The larger employers, which refers to a very broad group, really covers those with more than 50 employees. And here you'll see a varying range where many of them will be self-insured. And in the last several years, we've been seeing this trend where private payers are making self-insured options available to employers with as few as 100 employees, as many want to play a larger role. And then, of course, we have the uninsured market. So these are individuals that don't have access to health coverage, and they're really the ones who are managing their overall costs on a day-to-day basis. Another thing I just wanted to bring up are a couple of key concepts as we think about how payers manage their population. So payers receive premium dollars to insure members. So again, a payer could be the federal government, it could be a managed Medicaid program, private payers, including insurers, employers, and providers. So in essence, there is a dollar amount that is paid to an insurer every month to cover that member. As we think about the population, scale is really important to manage the risk and then optimize the overall expenses. So thinking about more members in the overall volume that you have, that enables a payer to basically spread the risk and gives them the opportunity to ensure that they have as little variability in terms of their overall expected premiums and expected medical expenses on an annual basis. And then another thing to think about with volume is that the location and membership density is also very important. If you think about the plans that operate state to state versus national, if you have a very large density and a great population concentrated in certain geographies, that gives you leverage as you think about negotiating the reimbursement rate for various care delivery expenses, diagnostics, labs, et cetera, with the various care providers in your state. Many of you have likely heard the term medical loss ratio or MLR. It's very simply just the overall medical expenses for a particular population divided by the total premium dollars. And there are certain regulations out there that indicate that insurers, based on the audience, need to spend 80 or up to 85% of the overall premium dollars on specific medical expenses for their population. And then the last thing I would highlight is that there are a lot of a lot of payers, that will focus on various segments as you think about Medicare, Medicaid, or the broader commercial population. They may also focus on geography, but the reality is that the needs and the expectations of these segments are very different. A commercial population may not have as many people utilizing care as, say, the Medicare or the Medicaid population. A Medicare population where you're really focused on our seniors and our retireds is going to have very different needs from, say, a Medicaid population. Overall, what a payer does is they leverage a number of different tools as they think about how to really optimize consumer health and manage costs and ultimately support the patients on their healthcare journey. And I'll just spend a little bit of time here on the next page talking about some of these different approaches. So the first is they will create what's called a plan design. This essentially defines the covered benefits. This refers to the office visits, inpatient, outpatient services, labs, diagnostics, et cetera, anything that might be covered. Now, this is growing as we think about the different offerings. So things such as genetic testing and infertility were not typically things that were covered previously, but are starting to emerge as covered benefits based on the needs of various segments or the requests of the employers. We're also starting to see too, for the government beneficiaries, Medicare and Medicaid, much more focus on the social determinants or social drivers of health as they're referred to, thinking about food, housing, transportation, and securities and other things to just overall manage the general health of those populations. Then what a payer will do is they will establish a network. This refers to the contracts that they initiate between various care providers in their market or on a national basis. So this could be constructed in a number of ways. They might have narrow networks where they're focused on a very limited number of providers that they contract with. They're also looking at those providers that are going to be inside their network versus out of network. Ultimately, what a payer is trying to do is create a broad set of services where those individuals who are covered under their plans can gain access to the care that they need. But the payer is also responsible for making sure that they're going to high quality and very efficient providers overall. The other thing that we're seeing is cost sharing. So this is something as we think about the consumer payment obligations. So payers operate as the third party, and they are responsible for paying really the bulk of the overall costs associated with medical utilization, as we refer to it. But it's important to keep skin in the game for the consumers. So many of you have probably heard about things such as copays, which might be a certain amount that consumers will pay to go to an office visit, or maybe there might be a copay associated with an outpatient service or an inpatient stay, a cost per day that a patient may need to pay. Then there's often a deductible, and what a deductible refers to is a threshold amount that the individual patient must pay before really the coverage and the support from the insurer kicks in. So for many people, they might have a deductible of $500, which means that the first $500 that they spend in medical care comes out of their pocket. After that, there will be support from the insurer for the remaining payments. And those remaining payments are referred to as coinsurance. So that determines then for additional dollars that the individual patient spends, how much of that is going to be covered by the patient versus the health insurer. In many cases, you might see that the insurer will pay 70 or 80% of the next set of costs. The individual patient will pay 20 or 30%. And then the last feature in cost sharing is what's referred to as an out-of-pocket maximum. And the out-of-pocket max basically indicates what's the maximum amount or the overall limit that an individual patient is going to spend on their medical costs on an annual calendar year basis. So let's say the deductible is $500 and the out-of-pocket max is $1,000. Once the patient spends $500, let's just say that in between the $500 and the $1,000 out-of-pocket max, there's a coinsurance of 80%. That means that the next several set of expenses, the insurer will pay 80% until that patient has reached the maximum threshold of $1,000 spent. And then the last thing I'll highlight here is we also look at a lot of clinical and medical management programs. This could be care and disease management programs focused on overall solutions or specific solutions tied to chronic conditions, diabetes, cardiac, oncology, musculoskeletal. This also includes various ways to engage the providers, thinking about things such as prior authorization for perhaps diagnostics or various procedures for certain conditions. It's also ensuring that the providers are complying with things such as evidence-based medicine. And then, of course, there's case management for various patients that have needs extending across an entire health system or very, very chronic conditions or catastrophic events that they're looking to manage. And I mentioned at the very beginning that we have our federal and state governments that serve as payers, and they're also regulators. And virtually all of these are subject to regulation and federal and state oversight from a private payer perspective.
And Liz, we have one question if you'd like to take it now. The question is, can a digital health company offset the patient's copays or deductibles in order to encourage the patient to use their virtual care services?
That's a great question. You know, what some of the payers might do is look at having either no copay or a smaller copay amount for things such as virtual care services. So we're starting to see some of our payers operate and offer some of these different, I'd say, tiered benefits is what it's referred to. So for the first line of care, if you're going to a telehealth provider and having a virtual visit, there might be a $0 or let's just say a $10 copay. If you actually end up going in to see a physician, that might be more of a $20 or a $30 copay. So they might tier some of those benefits depending on how they want to drive utilization as they think about the population that they're managing. So great question. Couple of other things, just as we see this, risk is really what an insurer is trying to manage. So they're looking at the overall expected conditions for the populations that they serve and trying to make sure that they set the premium rates appropriately in anticipation of what the utilization is going to be. And one thing I would just highlight about an insurer is that because they are managing risk, they are very risk averse, right? So as we think about the payer population, what they're really trying to do is minimize the abrasion and the disruption. And I won't spend a lot of time on this page, but when you think about the fact that you have 330 million Americans, they're all spread across different categories in terms of how they access care. There's very diverse healthcare needs that exist across the different populations or in general. You saw the funding sources as you think about federal government, state government, and the different types of private payers. And then receiving care in a number of settings. While we have our traditional settings, the office visits, the labs, the inpatient stays, the outpatient facilities, we're now starting to see a lot of care transition into retail has been very popular over the last several years. And then of course, prior to and in general with COVID, moving care into the home. This is something that a lot of people are looking at because it's a way to better enable patients to get the care that they need that might be more timely or in a setting that is more comfortable to them. So as the payers are thinking about how to manage the risk and the cost, they have to keep all of these different sort of things in mind. And then one other piece that I wanted to highlight, and then I'll stop and take any other questions as well, is when you think about reimbursement across the payer spectrum, it is going to vary greatly. So Medicaid and Medicare reimbursement rates are established by state and the federal governments respectively. What tends to happen is that these rates may be lower than what the actual cost of the service is. So there tends to be what's referred to as cost shifting, where the employer market or the private market is basically making up the gap. And so if you look at this chart, this actually came from the Kaiser Family Foundation. At the bottom, it shows what if the Medicare payment rate is roughly at 100%. So think about just spending $1 on a Medicare reimbursement for a Medicare beneficiary. If a private payer is coming in and they are looking overall at their hospital expense, they are spending upwards of double that amount or 250% of what a Medicare beneficiary is spending for that same cost. And you'll see how that varies widely. Outpatient services being the most expensive relative to the Medicare reimbursement rate. The easiest way to think about this, for lack of a better way to describe it, is if someone was going to the grocery store and they were looking at a box of Cheerios and the box had a different price associated with it. If someone was on food stamps, let's just say they may pay $2. If someone has an AARP card or is Medicare eligible, they may pay $3. And anyone who does not have that and is covered individually or through private payment, they might pay $5 or $6. It's the same service, it's the same product or offering, but there are just different reimbursement rates. And to give you an idea of how much this has actually continued to exacerbate across the industry, back in 2010, Milliman, which is a national actuarial firm, did a study and they found that the overall reimbursement rate for private insurance relative to Medicare was about 140%. They anticipated that it would be about 166% by 2020. So here we are in 2022, and we're seeing that there is a lot more expense associated overall. So this is also how payers have to think about managing their networks and managing the overall utilization for the populations that they serve. So before I jump to the next section, I will stop right there and see if there are any other questions.
We do have a couple of questions. The first is, how can a diagnostic startup learn the pain points of self-insured payers with potentially large at-risk populations? They say the CMS data is available, but private payer data is black boxed.
Yes, private payer data is hard to get to. And I think a couple of things, you can leverage what's available from a CMS standpoint and what is available publicly. But what will also be helpful is to think about what is the overall risk of the commercial population relative to Medicare. So let's just take diabetes, for example. When you think about the proportion of the commercial business that has diabetes relative to the Medicare business, it's only about a quarter of the overall population. And so you just need to think about how frequent is that particular condition diagnosed? How extensive will this type of a diagnostic be leveraged for a commercial payer? Many of the diagnostics that I have seen do start with the Medicare population. Some may go to the Medicaid population if there's a good opportunity to get more of those patients engaging with the healthcare system. But it will depend on the category, the disease state that you're looking after, and then the overall utilization that they're seeing, or overall proportion of members who have that particular condition.
All right, and the second question, for a medical procedure done at a hospital requiring a medical device, is it the payers or the hospital that would have a greater influence in approving a new medical device for use at their facility?
That's a great question. Really, a lot of that is going to be driven by the providers. And so what payers are going to look at as it relates to a device, and this will be a little bit of a preview, so I'll spend less time on this in subsequent pages, but as payers think about what they are going to cover, They are going to look for the evidence. They are going to look for approval from various regulating entities, FDA, et cetera. They are going to look for the input from key opinion leaders, associations, et cetera, who validate the usefulness and the efficacy of the various treatments. But ultimately, the decision will be the provider, as long as it is a covered benefit, as long as it is a covered device, it will be up to the provider to determine what they believe is best for their patient, working with that patient and what they prefer as well.
We have one more question that came in. What is a typical way that payers pay digital companies for their services? Is there an acceptable style rate, PM, flat?
Great question as well. I'd say traditionally has been more of a per member per month, PM, or in some ways a per employee per month. I will be very candid. Over the last several years, there is what I've referred to as PM fatigue. What has been happening is that there are a number of different initiatives. And when you think about it from an employer standpoint, as they think about adding either different digital solutions or different sorts of care management programs, so many of these have an associated PM cost. Now, some of them individually may not be that expensive when you think about adding it broadly across the population, but it can easily add up. And so employers and payers are looking to find more opportunities where they can work with companies that either want to put their fees at risk or are willing to do some sort of a value-based component where they can look at demonstrating the efficacy or the improvement in the overall quality or outcomes for the populations that they are serving. I don't want people to walk away thinking that a PM will not work. But again, it's been a little bit more challenging from a sales perspective to get more employers and payers willing to continue to expand their offerings by just adding that PM fee for the populations. Okay. So a couple of things. Where are payers really interested? And what are they focused on as they think about how to manage? So again, they're very risk averse, but what are the things that are really important to them? First and foremost, it's the outcomes and the cost. It's the patient health. It's getting them the right care, ensuring that they can help them utilize the benefits that are available to them, that they're getting to the best providers. So thinking about ways to manage those provider negotiated rates, the reimbursement, and then also thinking about some of these emerging diagnostics and technologies that can improve how we can either diagnose patients or allocate their services to get them to the most optimal treatment path or therapeutic. They're also thinking a lot about data assets. So I mentioned earlier that volume is really important, and being able to assess and really forecast what the overall expenses are for a population is a critical priority to a payer. So anything that will help with the ability to identify what the potential risk might be, gaining insights on the populations and their needs, being able to better understand where there may be this emerging, or as some in the industry have referred to as the rising risk. If there are ways to identify, just to kind of use an example, which patients may progress from prediabetes to diabetes more regularly, right, or more routinely, or being able to kind of forecast based on certain activities who might actually have some sort of an emerging event is of great value to a payer and to employers. The other things that they're thinking about from a data asset perspective is optimizing the concern around fraud, waste, and abuse in the industry, overcharging, incorrect reimbursement, things like that, making sure that the right patients are getting the right treatment, but not being over-treated unnecessarily. These are other sorts of things that payers pay a great deal of attention to. They're also going to think about the member experience. The reality is there are numbers of patients who do not interact with the healthcare system on a regular basis. And I'm sure many of us have experienced either personally or with our family members, when someone has a new diagnosis, chronic or catastrophic, it can be incredibly overwhelming. You feel that you're in a very vulnerable situation, and going through pages of your summary of benefits or figuring out which providers to engage with can be really time consuming and burdensome. So there's a number of initiatives that are going in and investing in ways to think about how we can provide more advocacy services or streamline things through digital care solutions, as long as we're really thinking about these patients and how they're interacting on a very infrequent basis to make it as easy as possible for them. Because the last thing you want a patient to have to do when they've just had a new diagnosis is figure out how to utilize the online tools or the digital solutions. We want to make this as easy as possible. And payers in particular too are really thinking about what's the overall member experience, and particularly for the government beneficiaries, what's the satisfaction of their interaction with the healthcare system, which in many ways is challenging. So any support that can be provided for these patients is of critical benefit. And then the last thing they're going to think about is what's the overall impact to the population. And when you think about the role that a payer plays, they're really kind of situated in the middle. So they're thinking about the consumers and the patients they serve and their families. They're thinking about employers, the providers that they're working with, community organizations, because they're looking for other ways to provide more extensive resources and support to their populations. They have to think about regulators. Many of them are also public entities, so they're thinking about shareholders. They're also thinking about investors. And given other partnerships that they have more broadly with potentially diagnostics or other care management assets, they're thinking about things like that as well. So this is always in the back of their mind. So I'm going to quickly go through here, because we've touched on a couple of these items. How do payers really think about creating value, and how are they evaluating new opportunities? So there's kind of 4 key areas, and I'll break them out on the following pages, but it's really looking at what's the opportunity that can be solved and who's going to benefit from it. What are the attributes of the various solution or product or offering that make it attractive, and how disruptive is it really going to be in the market? Where do we see demonstrative value, what's been proven to date, and then how are we going to pay for it? So as a payer thinks about what's the opportunity, what's really important as you're getting in front of them is, can you clearly define what is the opportunity in the area of need? And then how is the value? What is the value that you're going to deliver, and how is it going to be delivered? Many people think about value in terms of reduced cost or utilization. It could also be things around reducing their administrative costs as well. It could be increasing quality or satisfaction, things that will actually influence scores that are very, very valuable, especially to the Medicare payers. Can you bring new insights that will help with accuracy and efficiency overall, that will help them price better or anticipate what the risk is of a population? And then there's another feature that's utilized in many of the segments called risk adjustment. And what that is looking at is reimbursement, say from CMS for the Medicare beneficiaries or for the individual exchange population, is going to be based on the risk mix, as it's referred to as the overall population. So let's just say you have a population of 10, and one payer has 5 diabetics and 5 healthy members. Another has 5 diabetics, 2 cancer patients, and the rest are healthy. Another might have 5 diabetics, 3 with cancer, and 1 who may have some other sort of an autoimmune disease. They're going to look at balancing the overall risk or making sure that payers are compensated fairly for the overall risk of their population, because what the regulators are trying to preclude is having these payers only go after and cherry pick, as it's called, the younger, healthier population that may not utilize care. So the risk adjustment piece is very important and very valuable as payers think about how to manage their populations and the overall reimbursement and premium dollars that they receive. It could also be too things that improve their bonus payments or incentives as we think about working with the federal government or with state Medicaid programs, and even from commercial employers. Some may have particular targets out there in terms of how they want to see their overall population serviced. They're going to want to know, how big is this? How many members are you going to impact? What conditions? What segment are we talking about? And how big is it overall? It sounds a little crass to say that they're really going to focus on the higher cost, higher value items. And that's really primarily because they're looking at having as big of an impact as they can on their overall population. And while there may be some offerings that are very valuable, if the individuals that are potentially going to benefit from this represent such a small population within the overall membership that they serve, it may be difficult for a payer to warrant spending time in those sort of areas versus something that, say, is going to have a massive impact for 25 or 30% of their population. And then they're also going to think too, from an industry or segment standpoint, what are the regulations that I have to be concerned about here? Am I going to be at risk of non-compliance, or am I going to potentially violate any existing rule that exists in the market of how I need to manage my members? Or do I already have contracts with providers to service these patients in various ways? So all of these sort of things are going to factor into their really kind of their interest level up front. So if they are interested, then what they're going to really want to understand is, how unique is your solution? How innovative is it? What are the features, the design? What data do you bring? What results do you have? They're going to wonder what your overall engagement rate is for the consumers, both initial and ongoing retention of those members. They're going to wonder what type of risk it's going to identify or evaluate and support, or what sort of weakness they may have internally that they're not able to capitalize on that you can help fill. They'll think about the brand, impact to the brand and overall awareness. And they'll also think about the timeliness and ability to execute. Many of you are likely aware that the payer timeline is pretty rigid, and decisions tend to be very specific and measured. And so it's a long cycle to work with a payer or an employer in particular. And so just thinking about how you need to demonstrate your uniqueness and the innovation that you're bringing is very important. They're also going to think about whether or not it's even valuable to have an external partner. In some ways, a payer is going to think about whether or not they may be at a risk of disintermediation, or they're going to think about whether or not the patient would find this valuable, and if they would actually appreciate having it from a different party than the payer or the employer. Many of the national and regional payers have invested considerable capital in developing their own programs and tools. Doesn't mean they have everything perfect, but they have invested quite a bit to make sure that they have a fairly streamlined consumer experience. Your ability to integrate or easily replace some of these existing tools is also going to be of paramount interest to them. And then I mentioned earlier on the prior page, just how disruptive will this be? There's some healthy and necessary disruption that they are going to want to introduce, to think about ways to improve care. But if it is going to massively, let's say, disrupt their network and cause providers to want to pull out of their network, or if it's going to create a bunch of abrasion and inhibit how a patient may access care, or cause them to go to a facility, let's say, that's 20 miles further away from their home, they have to be thinking about all of these sort of things, because the reality for a payer is, in the court of public opinion, if you just apply the Wall Street Journal or the New York Times test, a payer is not going to win out. And many of you have likely seen this play out in your local markets. It's very difficult for a payer to gain sympathy, let's just say more broadly, even though they ultimately are trying to do the right thing for the population. Then we talked a little bit about this earlier. What they're going to look for from any of these new offerings coming forth is, do you have the necessary approval? If you're coming forth with a new diagnostic or a lab or something like this, a new medical device, do you have the necessary approval? Do you have the right influencers, associations, key opinion leaders who recognize the value of what you're delivering and can operate as a resource and a reference as they think about engaging with other providers and seeing this utilized more broadly? Have you validated your solution? Have you done pilots? In what markets, of what size? Or are you looking for the payer to actually participate in some of your pilots, and what's the value to them? What partners do you have? Existing customers, what's been the engagement and retention for both the customer themselves and their population? And if you, again, are looking for a payer to be a partner, what's your hypothesis for the earlier stage in intervention? Are you thinking about the overall engagement and gaining access to more patients than what a payer would typically be able to get on their own? Are you able to deliver stronger results from a clinical outcomes perspective? All of these sort of things will be very important to them. And then the last piece too is they're going to think about, we talked about this earlier, what's the reimbursement and what's the payment? So as they think about this, will it be a medical or an administrative expense savings? Will there be other value associated with this? Again, the ability to think about risk adjustment or quality or satisfaction scores, ultimately the STARS impact. How will this be paid for? Will it be a per member per month? Will it be more on a per usage basis, paid by the drink as we kind of refer to it? So if you have a diabetes program instead of a PMPM, are you going to look at having a per member, per engaged member expense, which will be higher than the per member per month? But sometimes that's easier for payers and employers to wrap their head around now. It's not, I'm just paying broadly for everyone. I'm really paying for the number of people that are actually using the service. Payers are also going to think about how interested will employers be in this, and would they be willing to pay, or is this something that a payer is going to need to offset as they think about managing their broader population? They'll also think about the other market costs. Is this going to require some regulatory approval and incremental filings that they wouldn't have had to do otherwise? Is this going to require broad-based marketing or brand spend to make patients and providers and other constituents aware? And again, in the court of public opinion, is this going to be something where if it shows up on a national level on the news, how is that payer going to be perceived? The last thing they're going to think about too is, what is the total cost of this? What's the overall investment that they're going to need to make? How long is this going to take to really implement? How quickly will you be able to engage new members? So is this going to be a year or two to actually build a program or build something from a technology standpoint or a consumer marketing perspective, and it's going to be another 6 to 8 months after you have this ready before they're going to start to see the first patient? Those are the sort of things that run through their mind. And the last thing I'll mention here, and then I'll stop and take any questions, is payers really operate primarily on a calendar year basis. I think it's something like 90+% of our country that is enrolled in benefits is on a calendar year perspective. So that means that the benefits start in January and they end in December. So as payers think about how they need to submit the different plan designs and networks to be approved by state regulators, generally in the first 4 to 5 months of any calendar year, they're looking at the different types of benefits that they want to expand. And then they're either getting ready to submit those to regulators or present those to employers who are doing their own types of benefits if they're self-insured in kind of that May, June, July timeframe. Then they work through the overall process to get those approved. And then you have open enrollment timelines in the fall. Medicare has set open enrollment timelines in the October, November period every year, October, November, December. Employers have their own open enrollment timelines in similar calendar months. And that's all because they need to find out what plan design people are choosing, the network, et cetera, so that by the time things roll around by January 1st, they have those members enrolled and ready to go to utilize coverage. So payers have very established timeframes, so their window to evaluate and make decisions is very short. And this is why the sales cycle is very long. If you're really unable to get a payer to make a decision in the first or second quarter of a calendar year, you're likely going to have to wait until the second year, unless you're able to work with them on some sort of a pilot program or market study in the interim. So I will pause right there. Carly, are there any other questions before I go to the last page?
Yes, you do have some questions. First, is there a general threshold for the magnitude of impact on costs that needs to be hit for a new solution to be of interest to a payer? For example, minimum saves us $10 million per year.
It's a great question. It will vary by the payer, for sure. You may have a local payer where $10 million is absolutely exceptional. You may have a large national payer where, not that they're going to sneeze at $10 million, but it may not be as meaningful as some other expenses. What's also really important too is to think about who benefits from the cost reduction, because certainly you as the new entity, are going to want to be able to take part in some of the savings. The payer certainly will. Perhaps the patient or the employer will. So I'll give you an example. When I was with Anthem, I was working with a wonderful company, and they had a new capability where they were looking to manage the overall interactions for patients with diabetes. They factored what an overall 10% savings might be for the average member, but they looked at keeping that entire savings for themselves. And so we needed to work with them to say, you can't assume that if you save a certain amount, that is all something that is going to go to you, because ultimately what payers want to do is be able to provide some incremental value to their end patient or to any other constituent that they're working with. And ultimately the payer is going to want to save for themselves. So you need to think about, based on your overall cost equation, how would that be distributed in terms of the overall savings? And does that really get on the radar for a payer?
And another question, how big an issue is prior authorization? I have heard arguments that the payers and providers spend a lot of time and expense going through the prior authorization process. Do patients have to wait significant amounts of time to get treatment due to this process?
It's a great question. This is sort of the highest point of abrasion, I'd say, between payers and providers. And it has been for a long period of time. And I think it will continue to be so. Payers are just looking to do the right thing for their members. And so they are following evidence-based medicine that would indicate for patients with specific conditions, what sort of steps should be evaluated or explored to have that patient engage in diagnostics, various screenings, maybe various procedures. Providers understandably don't like that because they want the freedom and flexibility to treat their patients as they see fit. I would say that the vast majority of prior authorization is able to be automated at this stage. We're looking at a lot of improved interaction between the payers and providers to think about how to streamline. Certainly, there are going to be more costly or complex cases that may require more in-depth case reviews. And I am seeing a lot of different organizations looking at how to either streamline the process overall, how to provide payers with the right amount of information and content that they need to make that decision, or how to provide providers with the insights on what are the sort of things that a payer would approve on a more frequent basis based on what these evidence-based guidelines provide. So long way of saying it is a point of abrasion. It is something where ultimately the payers are looking at how to optimize the care for the patient and to make sure that providers are being compliant and monitoring things overall. I think what we're finding too is the vast majority of providers are compliant, and payers are also looking at ways to really streamline, or some of you may have heard of this concept, they're calling it gold carding. So now that we have a lot of AI capabilities, maybe there are certain providers that can have all of their approvals just automatically authorized. And then the payers over time will go back and look at the variances that they might be seeing and identify if there may be any points that they need to revisit, or see if there are any inconsistencies between prior authorization approvals.
All right, there's a few more questions, but I'll give you some time to finish, and we'll take more questions at the end if there's time.
Great. And there's actually just one other page too. So what I'd also say is, when you think about engaging with a payer, there's a couple of different things to think about. First, what type of payer do you want to engage with? There are the national payers who certainly have a tremendous amount of membership, but they also tend to move a lot slower. They also tend to have a lot more of their own programs, tools, digital solutions, things like that. So it might be a little bit more challenging to get in front of them, but the payoff could be very big. As you think about regional or local players, there's a lot of blue organizations that have a very strong presence in the state or across multiple states. There's also a number of regional players as well, who Medica, for example, is one that operates in the Midwest, and they're typically in about 6 or 7 different states. So that also can give you a good access point. And a lot of these regional and local players haven't necessarily invested as much as a national payer in terms of the overall capital improvements, not because they haven't wanted to, but just for their realities. If you want to work with an integrated provider like an Intermountain or a Kaiser, they're going to have their own structure and approach. Similarly with the provider. So really think about who's the type of payer that would benefit the most. What segments do they operate in? Are they in the segments, as we think about Medicare, Medicaid, commercial, that would benefit the most from your solution? And how might you think about engaging with them? I would be very specific on the ask. Do you want them to invest? Do you want them to be a customer? Do you want them to be a pilot partner? And then be very, very clear about what problem you are going to solve. That, I think, is one of the biggest challenges that I have seen with a number of companies, is that they come in saying that they can do a lot for a large number of the population. And the reality is, the more specific that you can bring and the more that you can articulate very clearly who you will be able to help and how they will benefit, that will go a long way. When you think about who to engage with, a lot of people will look at the lines of business. So by lines of business, I mean the Medicare, Medicaid, or commercial markets. And within commercial markets, you'll have the large and the small employers. So again, be very specific about who you want to be introduced to. Having an audience with the actuaries or the finance folks, particularly if you have your story very well defined on what the overall cost equation is and how you can help them, will be very useful to you, because the actuaries and the finance teams inside a payer organization are exceptionally influential, especially in several of the larger institutions. And then if you are looking for an investment, there's a number of them that have corporate venture capital or corporate development teams that are looking at minority investments. Now, that doesn't mean to only look for those particular individuals. If you or others on your advisory board or your board of directors have relationships inside those companies, definitely leverage them. But what I would also again emphasize is being very, very clear on what you are going to do, because depending on where you start, the more clear you are, the easier it will be for that individual to route you to the right person and to even be your internal champion if there's something that is well defined versus something that might be a little bit more nebulous or perhaps lack the clarity that they're looking for. And then I mentioned a couple of pages ago, just the timing, thinking about the calendar year, regulatory reviews and approvals, open enrollment periods. The other thing too is within a large payer, again, they're very risk averse. They're thinking about ways to manage their populations. There are often a lot of internal committees and reviews that need to occur, either within the specific line of business or the business segment, within capital committees, within, depending on your offering, medical or clinical committees that are looking at evaluating these new solutions and innovative devices that are coming to market. So there will likely be a number of these different internal reviews that you will need to step through as well. And with that, I just want to thank you all for your time. I know that's a lot to grasp. I hope I was able to chunk things out a little bit, but I realize that some of the concepts and things like that are very, they're very, let's just say, cumbersome at times, and there's a lot to think about from a payer perspective, but I've enjoyed the questions, and I'll turn to Carly to see if there are any more before we close things out.
Thank you so much, Liz. Maybe we have time for one, maybe two questions. The first is, when is the most appropriate time for an early stage medical device company to start the conversation with a payer? Who should be targeted to begin these conversations?
Yeah, that's a great question. I think first and foremost, you need clinical evidence and some pathway to approval through the FDA or whatever the regulating entity is. If you've already filed and you're going through that process, that's great. But if you're too early stage, you're going to get pushback right away. I think as you look at starting out, it will depend on whether or not you want to have that payer potentially invest in your company. The corporate development team or one of the innovation groups may be of use. And then you ultimately will need to go through with a medical review. And that is with a group of clinicians who, again, will be looking for what is your regulatory approval? Who are the key opinion leaders and associations that are referencing this as a valid and efficacious opportunity for the market?
Great, Thank you. And I think we'll just stop there for today. There are some more questions, but it looks like Liz has her email up there. So I'm sure she would love to answer any offline as well.
Absolutely. Look forward to it.
All right. Thank you again for your time, Liz. It was great to hear your insights today.
Wonderful. Thank you all. Have a great afternoon. Appreciate the help.